Today, we are going to delve into the pivotal role that our clinical team plays within ACA and Life Plan CCO. Thank you for joining us. Today, we're going to explore how our skilled clinical team members are not only supporting care managers, but also driving health promotion strategies, specifically tailored for our members with intellectual and developmental disabilities. Additionally, we're going to share some insights from a recent population health data that we collected and presented at the AAIDD conference this past spring, which highlighted the progress and impact of our initiatives. Our goal is to give you a comprehensive understanding of our team's efforts and the meaningful advancements we're making in supporting the health and well-being of those we serve. Between ACA and Life Plan CCOs, we provide care management for approximately 45,000 adults and children with IDD in New York State, which is about 40% of the state's IDD population enrolled in OPWDD services. One of the primary goals of the clinical team at ACA and Life Plan is to ensure that we are using a whole person approach with our members. We're not just looking at coordinating services pertaining to their IDD diagnosis, but we are also ensuring that they have all of their primary, acute, and behavioral health care needs met as well. Our clinical team consists of two primary teams, nursing and behavioral health. We have registered nurses who focus primarily on health and medical issues, and then we have a team of behavioral health professionals who specialize in dual diagnosis and connecting our members with resources in the community that pertain to behavioral health issues. So combined, these two teams provide member-specific consultation to our care managers. Upon request, a care manager can request consultation with our team. We also work to proactively identify high-risk members who may benefit from that additional expertise, and we bring that expertise to the care manager to support them in their role in coordinating care. Our team also contributes to training our care managers in specialized topics, as well as developing wellness resources for members and families. In addition, we have a small team that works on population health research, and that is what we will be going into later in this presentation. So as I said, we're working to be more proactive with identifying those members who are probably most at risk for instability and negative health outcomes. So we often find that the teams are so busy putting out fires and dealing with crisis situations that they may not see an opportunity to act early in the progression of that upcoming crisis. So one approach we use is represented here in this pyramid graphic. This shows how we are using something called risk stratification to categorize our members into levels of risk. This helps us identify where our resources are needed most to improve overall health outcomes for all of our members. And then it also highlights those opportunities to be proactive in keeping our members healthy and safe. Historically, our clinical team has been heavily involved in some pretty complex situations that would fall mostly up in that red triangle you see at the top where it says crisis. And we will continue to support care managers with those members. But in the coming year, we plan to expand our focus to those middle levels in the yellow and orange. Those are the opportunities to act prior to crisis. But before I get to that, I want to share a bit about how our care managers can access support from the clinical team so that our providers know how that works. Member with particularly complex clinical issues, they would normally discuss that case with their supervisor to get assistance. If together they feel that this is a situation where a clinical consultation would be useful, they request that directly from our clinical team here at CCA. We would then meet with the care manager and supervisor. We would review records and develop recommendations that the care manager can then bring back to the member, the family, and other members of the interdisciplinary team, including provider agencies. The consultation process is time limited, and most cases are closed within 30 to 60 days so that we can support as many members as possible. We also know that we have other teams within CCA, Life Plan, and ACA that find out about risk factors or members that may be in need of additional consultation. And so our quality insurance, our incident management, provider relations, and member relations teams often will trigger a clinical consultation request through the care manager. Now, providers can ask a care manager to consider making a request for a clinical consultation once your provider agencies have utilized your internal resources. So we know that you have nursing, behavior specialists, psychologists, and we know that you would be consulting those individuals, prior to turning to the care manager. But if all of those internal resources have been exhausted and you're really stuck and really concerned about a member, you can certainly talk to the care manager and see if they would consider making a request for us to consult. And then we would consult with that care manager and possibly, work with you together in a team fashion. But those recommendations would be made through the care manager. Oops. Okay. So here's another, just a list of some of our other recent initiatives. One of the things I want to point out is that our clinical team is working with provider agencies that support CSID or Center for Start Services. We want to make sure that that crisis team is connected with the care manager and vice versa to ensure that those teams are working collaboratively. Under number 4, I wanted to mention that we have an annual project called our Quality Improvement Project. And this is a clinical initiative that is separate from our other duties where we select one target healthcare metric to impact. In previous years, it has been things like ensuring members are getting an annual physical. Last year, we focused more narrowly on high-risk members with diabetes and making sure they had their A1C testing done, things like that usually pertain to some kind of preventative health initiative. When our members live in a residential program, the care manager may be reaching out to request some of this information. And then finally, as mentioned, we're looking for new ways to identify members in those yellow and orange sections of the pyramid I showed earlier. So we are also looking at ways to utilize our existing data from assessments to highlight risk factors. So what we did was we listed out those risk factors and grouped them into 5 subdomains. The first 4 of these, disability, health-related, behavioral health, and social need factors, those are considered things that add to someone's risk. And then the 5th one we called supportive factors. Those are things that we think would provide some protection or offset the risk of those other factors and really buffer the person or protect them from having a negative health outcome as a result of the other risk factors. So it's kind of like 4 positives and 1 negative. With this, we've pulled this all together into something we're calling our vulnerability index, and you may be hearing more about that going forward. But this is just a little preview of what we're doing with that right now. So now I'm going to shift gears and talk a bit about some of the results of our recent research we've been doing on population health. So the reason we do this is to identify trends across large groups so that we can identify what is and is not contributing to negative and positive health outcomes for all of the reasons I've mentioned earlier. Of course, there's tons of research on health outcomes in general, but there's less so in the IDD population. And we know that what may be true for the general population may not necessarily be the same in those individuals with IDD. We know that those individuals are more at risk for health disparities. And we really want to understand why that is and also what we can do about it. There have been relatively few large-scale studies of New Yorkers with IDD across age groups and place of residence that is aimed at trying to better understand the healthcare needs of this population. There have been some, and there have been some in other larger data sets across the country, but relatively few. So we're still in the early stages of this type of research. So this is a very exciting time for us. Our focus today is on a subset of the entire population, which is high utilizers of emergency rooms. You may also know them as frequent flyers. We're interested in understanding why these individuals use the emergency room more frequently as a group, and what are the factors contributing to this high utilization. this preliminary analysis that we did was looking at group differences and was aiming to identify risk factors for some targeted interventions so that we could try to intervene. This was a preliminary analysis. It really compares differences between groups, not so much looking at individuals. It's not meant to imply any sort of causal factors. It's really more looking at correlation and what is happening as these hospital visits are occurring in real time. And so it's not a longitudinal study. We may be doing that in the future, but we're just trying to start to identify what some of the drivers of utilization might be. And in the future, what we're hoping to do with this intervention, with this research, is to guide future research and look at more complex risk stratification models. So in our study, we considered several factors. And as I said, this was presented at the AAIDD conference in Louisville, Kentucky, back in June of 2024. So in our study, we considered race and ethnicity, place of residence, and age as the specific variables we wanted to look at in this group of high utilizers. Now, previous studies have shown that Black and Hispanic populations do have higher ER utilization rates. And we know that in residential settings, for instance, we might see higher ER use because of required assessment for certain incidences, such as falls or seizures and things like that. So those were some groups that we thought we might see a higher tendency for ER utilization and those high utilizers specifically. We also know that older and younger populations are at higher risk of ER visits. So that was why we looked at these three risk groups. So this is just a look at the demographics of our total sample, which was, we did have some constraints on our data. So you'll see that total count is closer to 41,000 when, we really do serve around 45,000 total. But this was the data set where we were able to get the complete set of everything we were looking at, which is pretty typical in studies of such large data sets. We do see here, we broke it down for you by race, ethnicity, sex, and age. What may be notable is that the majority of our members are white, that's around 69%, and non-Hispanic, with a larger male representation. The age distribution down here on the bottom shows a significant portion of our members are in the age range of 18 to 49. And then we also broke it down by place of residence, which will be one of our dependent variables along the way. You may be wondering what other place of residence. That just means it might be supervised residence, but not necessarily regulated by OPWDD. So it may be like a temporary OMH respite facility or someone who was in a rehab hospital at the time that this data was pulled, things like that. We pulled this data from different sources, some of which are more reliable than others. So we actually think that the number of people living alone is probably higher than 4%. And we're working on, this was a good opportunity for us to see where some of our data needed to be cleaned up a little bit. And so we're looking at trying to improve that data for the next time we do a study like this. We also have this broken down by the level of intellectual disability. And as you can see, we serve a range of levels of intellectual disability. And then you can see also that about 42% of our members have a diagnosis of autism. So many of those individuals also have some level of intellectual disability, but not all. Out of our overall sample, we identified about 3,800 high utilizers in our sample, which was about 9% of our population. And so how we just anyone who had 2 or more ER visits in the last 12 months. This group shows a mix of medical and behavioral health emergencies, so it wasn't just medical. And that really shows that there's unmet needs in both areas. And as you can see here, that was about 9%. So the people who met this criteria of 2 or more ER visits in the last month, like I said, it was about 3,800, and that was about 9% of our overall population. So I just want you to remember that number 9%, because that is when we look at our group as a whole, and we're going to compare that when we start pulling in those variables of other subgroups. So before we do that, I bet you're already asking yourself, who are these people and why are they going to the emergency room so much? Well, we want to know that too. We want to know why and what we can do about it. What's the root cause? When we look at the data provided by Medicaid claims, we can get some information. For instance, we would have thought that many of these ER visits would have been related to behavioral health issues. But in fact, that's not how it's showing up here. The overwhelming majority of Medicaid claims have a medical complaint as the primary reason for the ER visits. Now, if we took that at face value, we would think, okay, then we just need to get these people into better health care. But this pie chart may not tell that whole story. We've done some extensive chart reviews on these high utilizers, and it turns out that the underlying root cause of the ER visits are not always clearly falling into a medical or mental health bucket. They can be somewhere in between. So certainly, when the medical complaint is clear, such as maybe headache or upset stomach, there are many times where this was probably more of a manifestation of a more complex underlying issue. And really diving into these root causes is a bit beyond the scope of today's presentation, but I did want to share this with you and let you know that we're looking at ways to better capture this information so we can incorporate it into our data set and really get a better understanding of the overall trends and how we can impact them. But for now, we're really looking at the combination of mental health, medical, behavioral health all together. So over the next several slides, we're looking at high utilizers as they compare to non-high utilizers within these various subgroups. So here's an example. And we talk about risk of being a high utilizer in terms of, what percentage of that group falls into the high utilizer category. So right now we're looking at the percent of people who were high utilizers within each type of residential setting. So for instance, on that top bar, we have individuals who live alone in the community. Now, 14% of people in that group were high utilizers, which is shown in the gray color there at the top. The next group down are those living in certified residential settings. And in that group, 16% were high utilizers. So remember earlier we saw that pie chart and it showed us that the overall percentage was 9%. So that's what we're comparing to here. So just thinking about that 9% versus 14 or 16, already we see that living alone or living in a certified setting, you're more likely to be someone who falls into this high utilizer group category compared to others. And then if you break that down and look at the last two bars, so the rest of our members who either live in the community with others or in that other setting, we see that, comparison is even more drastic. So they really do break down into looking at those top two groups as being the higher risk for high utilization. There were also some significant differences by age group, which would be expected, particularly for those over the age of 50. We see that they're more likely to be high utilizers. Then we wanted to look at racial and ethnic groups. So you may recall that I think I mentioned earlier that there is some research on the general population in New York State and people without IDD, people with IDD. And there is some research that supports the fact that, race and ethnicity does seem to impact lots of health outcomes and ER visits being one of them. And there seems to be a consensus in some of the literature, such as those I've listed here, that Black and Hispanic groups are more likely to be high utilizers. So I really wanted to see if this was going to be true in our data as well. But instead of lumping Black and Hispanic together, I really wanted to look at those separately. So that's what we've got here next. Interestingly, when we just looked at race, we did not find there to be such a big disparity between those who are high utilizers and those who are not. The overall risk across all these racial groups is still pretty close to 9. I mean, 12 is a little bit higher, but not super significant difference from a statistical standpoint. So the most notable changes we saw with this, or impact we saw, was when we looked at race and age together, which I'm going to show in a few slides. We also looked at ethnicity, as I said. This also did not show a huge impact. And one thing I want to mention is that I did analyze this separately because, as you saw on the map, we do serve quite a range of geographic regions. And so I wanted to look where we probably have the largest population of Hispanic or Latinx, and that was in our New York City region. And when I just looked at that cohort alone, the data looked exactly like this. So that didn't really matter what region we were looking at, which was surprising to me. So as I mentioned before, we were able to see more significant changes when we started to take a combination approach. So for instance, combining race and age, which complicates the results, but I'll try to explain it. We started to observe that for those age groups, which is along the bottom here, the under 18 group, there was a difference between the Black and white population. So that 8.4% to 5.7%. That's a decent difference between those groups. So the Black population being a higher rate of high utilization. Then when you look all the way over at the other end, for those ages, once you get past around age 50, it switches. So where you see a higher rate of utilization for the white population and a lower rate of utilization for the Black population. And then also interesting to note that there was a consistently lower utilization among the Asian and Pacific Islander group. Did the same thing with ethnicity. So similar to race, we see that this ethnicity/age intersection does produce some interesting results. So we see, again, pretty similar with the Hispanic group under 18, much higher rate of high utilization, and the over 50 group, much lower rate of high utilization. Not sure what this means yet. I have some thoughts about it, but we're going to do some additional research to figure out. At the very least, it shows us that these are some risk groups that we want to understand better. So then we wanted to look at it based on where you live. So really, when you looked at race, the same, changes that we saw earlier seem to carry through regardless of your race. So you see all these lines are pretty parallel until maybe the end there. But you still see, generally speaking, those living in certified residence or those living alone are in the higher risk category between about 14 and 18%. So that means higher risk. Now, when we did the same with ethnicity, we do see a little bit more of a clear distinction. So this was one that really caught my eye. What is particularly interesting here is that for those who live in a certified residence, even though race didn't seem to matter much, ethnicity seemed to matter. So in a certified residence, according to this data, if you are Hispanic or Latinx, you have a 21% chance of being a high utilizer. Now, if you think about that compared to the overall population, and remember that what we're trying to do is identify risk groups that we should be paying more attention to, think about that compared to that initial pie chart of the whole group and that 9%. So the difference between 21% and 9% is very significant. So this tells me this is a group I want to start paying more attention to, and we will be doing that for sure. So it started, us thinking, what might be contributing to this, and these are completely hypotheses right now, but some areas we may look at examining within this group include certain, possible socioeconomic factors, access to preventative care, perhaps cultural attitudes that might influence emergency room use, and then certainly language differences. There may be other factors that, we're not sure of, but we're going to be trying to dive into that. Okay, so then we wanted to look at, a completely unrelated variable, and to see, if our data showed something that was a little bit more expected. So one thing is polypharmacy, and if you don't know, polypharmacy is defined as the use of three or more, in this case, three or more psychotropic medications, or two or more in the same subclass. That's how that was defined for this data pool. And polypharmacy tends to be associated with more complex medical and behavioral health conditions. And certainly our data shows that recipients of polypharmacy treatment are about 2.5 times more likely to be high utilizers. So there's definitely a strong link between this form of treatment and ER use. Again, this is not causal, so we're not saying that polypharmacy causes someone to be a high utilizer. It may be that people who are going to be high utilizers anyway tend to, require more medications. But it certainly, again, it indicates a group that we want to keep an eye on, because that is, again, from 9% to 22%. That's a pretty big jump. So taking this all together, trying to think about what we learned here, this is how I'm sort of looking at it. And it's just looking at, again, risk groups. So the highest and lowest risk groups that we identified was that, polypharmacy group, definitely high risk for high utilization, people living in certified settings, especially those who are Hispanic or Latinx, things like that. And while race and ethnicity alone did not significantly impact that risk, their intersection with these other factors definitely revealed some differences. So these are the ones I'm going to look at. And then we know, what we learned was that those under 18 or those living in the community with others, in other words, they're not in a residential setting, but they're not living alone. They're with, living with family, living with a caregiver, much less likely to become a high utilizer. So moving forward, we're hoping to develop a more accurate predictive model by incorporating some more hospital visit data, refining these risk groups a little bit more based off what we've learned. And we're going to continue to explore what the drivers of those ER visits are, such as looking at separating out medical and behavioral health visits and studying them separately. But we're definitely going to continue to include race and ethnicity in all of our data sets because we see that, there's definitely some interesting effects there that we want to keep an eye on. So that is our presentation for today. This was just a glimpse into some of the great work we're doing at LifePlan, ACA, and CCA&Y. And we thank you for joining us today.